Hello everyone, welcome back to my channel. Today we will be continuing the part 2 of hepatobiliary disorders. Hope you all are studying well and let's continue the topic. The first topic is cirrhosis. The cirrhosis, it is an end stage process with the binding fibrous septa. Most or entire liver involvement can be seen here. Regenerating nodules consisting of senescent and replicating cells. This cirrhosis can be classified into two parts on the basis of morphology. It can be classified as a micronodular, macronodular, or mixed. In micronodular, the nodules may be less than 3 mm, and in macro, it is more than 3 mm. On etiological basis, we can classify it as mainly as clinical, biochemical, or immunological. Coming to pathogenesis, in this, death of the liver cells with the loss of the architecture can be seen, fibrosis, regenerating nodules, and a vascular reorganization. The fibrosis may be due to the activation of the stellate cells. The activation of the stellate cells, as we have seen in the above in the previous video, that is, the main function is alcohol. The alcohol causes the activation of the stellate cells. Now, the next topic is portal hypertension. What is portal hypertension? The portal hypertension is the elevation of the hepatic venous pressure above 7 mmHg. The causes are, first, it may be prehepatic, posthepatic, or intrahepatic. In prehepatic, it is obstructive thrombosis of the portal vein. In post, it is severe right-sided heart failure, and intrahepatic, it can be cirrhosis or schistosomiasis. Note, there is an important note we should know. Most common cause of portal hypertension in adults is a cirrhosis. It is followed by non-cirrhotic portal fibrosis. In children, it is extrahepatic portal vein obstruction. The pathogenesis of this portal hypertension is there is increased hepatic resistance to the blood flow through the liver. It may be due to deposition of the fibrous tissue, active vasoconstriction. The another mechanism may be increase in the portal vein inflow. What are the consequences of this disorder? It may lead to ascites, formation of the portosystemic venous stents, congestive splenomegaly, and hepatic encephalopathy. Major clinical consequences may be hepatic encephalopathy, spider angioma, esophageal varices, cirrhosis, splenomegaly, caput medusae, ascites, and hemorrhoids and testicular atrophy. These are the main clinical consequences of portal hypertension. The next topic is ascites. As we all know that ascites, it is an accumulation of excess fluids in the peritoneal cavity. Now coming to pathogenesis of this ascites, we can see the main cause was portal hypertension. This portal hypertension increases the pressure in the portal vein, which may lead to ascites or hypoalbuminemia, where there is a decreased plasma oncotic pressure, splanchnic vasodilation, and hyperdynamic circulation, percolation of hepatic lymph into the peritoneal cavity. The above mentioned pathogenesis we can see through this diagram. The cirrhosis may cause portal hypertension or decreased albumin synthesis, decreased albumin, which may lead to transudation of the fluid. It increases ascites. Portal hypertension increases ascites. Lymph formation exceeds the lymph return. And splanchnic vasodilation, it is underfilling of the circulation, which causes a decrease in a renal blood flow, which causes the activation of renin-angiotensin-aldosterone system. It causes retention of the sodium and water, which causes increase in the ascites. Now, what is hemochromatosis? This hemochromatosis, it is an excessive accumulation of the body irons. There are two types, that is hereditary hemochromatosis, where the mutation of the gene encoding HFE transferrin receptor 2 or hepcidin. The mutation of gene encoding HJV, juvenile hemochromatosis. It is also known as juvenile hemochromatosis, where there is mutation of a gene known as HJV. Secondary hemochromatosis, where parental iron overload, increased oral intake of iron, and chronic liver disease. There may be tissue damage. The tissue are mainly damaged by free radical formation, activation of the stellate cells, interaction of the reactive O2 species and iron with other DNA. Now, the clinical features of these patients, the accumulation is slow and progressive. We can remember the triad by there is a micronodular cirrhosis, diabetes mellitus, and skin pigmentation. These three factors are more important than in this tissue damage. Now coming to our favorite topic, that is Wilson's disease. As we all know that it is autosomal recessive. It is a progressive accumulation of the toxic levels of the copper in the liver. There is a reduced incorporation of the copper into ceruloplasmin and failure to excrete copper into the bile. Hence, we can see there is increased concentration of this copper and reduced concentration of this ceruloplasmin. Coming to etiology. In etiology, we can see there is a mutation of ATP7B gene. Remember, ATP7B gene mutation, which leads to failure of excretion of the copper into the bile, where copper accumulates into the liver injury through ROS produced by Fenton's reaction. The main feature of this Wilson's disease is Kayser-Fleischer rings. This is seen in the eyes. It is due to the green to brown deposits of copper in the Descemet's membrane. This Descemet's membrane, it is a membrane or the layer of the cornea. Now coming to clinical features, it is mainly seen between 6 to 40 years, acute or chronic liver disease, neuropsychiatric manifestations. Now coming to biochemical features, as I mentioned above, there will be decreased serum ceruloplasmin, increased copper content in the liver, or increased urinary excretion of copper. Coming to biliary cirrhosis. The biliary cirrhosis can be of two types, that is a primary biliary cirrhosis and secondary. The first important is a secondary biliary cirrhosis. In this, we can see there is a jigsaw puzzle, piece nodules, small and large bile ducts distended with the bile, proliferation of the bile ductules and bile lakes. The next important topic is hepatocellular carcinoma. It is a malignant tumor derived from hepatocytes or their precursors, predominantly in the males we can see. What are the risk factors? The risk factors may be major risk factors and minor risk factors. The major risk factors can be remembered by the mnemonic ABCC and minor can be HCC. Okay. The major risk factors are chronic hepatitis, which may be HBV or HCV, and alcoholic cirrhosis, alpha toxin B1, non-alcoholic steatohepatitis. Coming to minor risk factors, it is hereditary hemochromatosis, Wilson's disease, tyrosinemia, alpha-1 antitrypsin deficiency, glycogen storage disease, oral contraceptives, cigarette smoking. Now, coming to molecular basis of this disease, we can see there is a mutation in the tumor DNA repair genes or activation of the oncogenes, that is KRAS, inactivation of the tumor suppressor genes. Now coming to this gross of hepatocellular carcinoma, there is unifocal, multifocal or diffusely in the infiltrate. The spread of this can be seen, it may be of local spread, lymphatic spread or blood spells. Note, there is an important note, all patterns of HCC have strong tendency for invasion of the vessels. That is, hepatocellular carcinoma have strong tendency for invasion of the blood vessels. Now coming to next organ, that is gallbladder. The main important feature of this gallbladder is it lacks submucosa. It is an only organ in our entire GIT which lacks submucosa. The normal functions are, it is a reservoir of the bile, concentration of the bile, secretion of the mucus, acidification of the bile. These are the main functions of our gallbladder. The important disease is cholecystitis. What is cholecystitis? It is an inflammation of the gallbladder. It mainly occurs in association with the gallstones. It may be of two types, that is chronic or acute. Now coming to acute cholecystitis, it is obstruction of the neck or the cystic duct by the gallstones. The gallstones cause the obstruction in the cystic duct. It causes acute cholecystitis. What is pathogenesis? Pathogenesis may be chemical inflammation. It leads to lysolecithin production, which is toxic, decreased glycoprotein, supersaturation of bile with the cholesterol, prostaglandins, and bacterial inflammation can be seen, which is E. coli, Klebsiella, Clostridium. Or mechanical inflammation can be seen by obstruction of the venous flow and ischemia. We can see the gallstones in the lumen of the gallbladder, densely acute inflammatory infiltrate, and we can see there is an ulcerated mucosa. This ulcerated mucosa can be seen. Now coming to hemorrhagic edema and acute inflammatory infiltrate can be seen here. Okay. What are the complications of this disease? The complications are emphysema of the gallbladder, gangrenous cholecystitis, perforation of the gallbladder, bile peritonitis, and gallstone ileus. Clinical features may be right upper quadrant pain, fever, leukocytosis. Now, as we have completed our acute cholecystitis, coming to chronic cholecystitis, it is the first is gross. In gross, we can see there is a normal or shrunken, smooth and glistening or dull due to fibrosis. Wall is thickened, opaque, and gray-white on cut section. On microscopy, we can see in mild cases, it is a scanty inflammation showing lymphocytes, plasma cells, macrophages in the mucosa. In severe cases, we can see mucosal epithelium normal or atrophic. The most important is a Rokitansky-Ashkoff sinuses. It is irregular shaped tubular structures formed due to invagination of the mucosal epithelium deep into the wall of the gallbladder. This is an important feature in the microscopy of this chronic cholecystitis. As I have mentioned, we can see there is a chronic inflammatory cells in the mucosa. There is a Rokitansky-Ashkoff sinuses, we can see, important feature. These are the muscle layer. In diagrammatic, we can see the plasma cells along with the lymphocytes, macrophages. See, this is a Rokitansky-Ashkoff signs which I was talking about. Now coming to cholelithiasis, that is gallstones. These gallstones are mainly of cholesterol, calcium, bilirubinate, and other calcium salts are the basic constituents of these gallstones. The important 5 F's to be remembered of cholesterol stones are fat, fertile, fatty, female, and familiar. The main is a fat, fertile, fatty, female. These are the features of cholesterol stones. Now coming to pathogenesis of cholesterol stones, we can see there is increase in cholesterol, decreased bile or decreased phospholipids. It leads to supersaturation of the bile. This supersaturation leads to nucleation, in which promote the factors which promotes nucleation are gallbladder hypomotility, mucin secretion, and calcium, which inhibits nucleation are apolipoproteins, lecithins. Now later, this nucleation where formation of crystal monohydrate cholesterol monohydrate crystals where leads to formation of microstones. This microstone undergoes a process of crystallization where accretion also takes place leading to formation of cholesterol stone. Complex multifactorial process where cholesterol supersaturation, gallbladder hypomotility, accelerated nucleation and crystallization, growth to stone sized aggregates can be seen. Now coming to pathogenesis of pigment stones, there are two types, mainly black pigment and brown pigment. The black pigment associated with chronic extravascular hemolysis, cirrhosis, mechanical prosthetic valves, Gilbert syndrome, cystic fibrosis. Now coming to brown pigment stones, it develops secondary to bile stasis and biliary infection. It mainly seen in the bile duct, rare in the gallbladder. It mainly seen in the bile duct rather than gallbladder. Like the cholesterol stones, these brown pigments, bilirubin glucuronidase, phospholipids, and conjugated bile salts may lead to calcium salt precipitation. The factors which accelerate precipitation are dead bacteria, parasites, and mucin gel, which leads to formation of brown pigment stones. The pathogenesis of the brown pigment salts. Now coming to complication of the gallstones. It may lead to cholecystitis, biliary obstruction, carcinoma, or acute pancreatitis. Last topic is carcinoma of the gallbladder. The carcinoma of the gallbladder, it is rare in females. It is rare and it is mostly seen in the females. The risk factors of this carcinoma are gallstones, porcine gallbladder, carcinogen, calcification of the gallbladder, GI disorders. Carcinoma of the gallbladder, the main feature is it is adenocarcinoma. The spread we can see it may occur by through that is a direct spread, lymphatic spread, or blood spread. Coming to morphology, this morphology under gross we can see it arises from the fundus and the neck, shows caliculi and marked fibrosis of the wall, diffusely infiltrating, exophytic or polypoid. It may be irregular or cauliflower mass-like structure. Now coming to microscopy, we can see adenocarcinomas, well-differentiated glands lined by layer of the cuboidal cells and embedded into the desmoplastic stroma. Clinical features are right upper quadrant abdominal pain, anorexia, nausea, vomiting, and there is increased ALP levels. So now we have completed our topic of gallbladder pathology. Hope you have liked the video. Please like, share, comment your thoughts, or you may ask questions which may you have doubt in your topic. We will try to answer your questions as soon as possible. Please kindly subscribe to our channel. Next pathology will be continued in the further videos. Thank you for patient hearing and watching.